So yeah, good morning, everyone. My name's Dr. Saleem Ansari. I'm one of the metabolic medicine registrars at Imperial. And I'm just going to give you a talk. It will last about 30 to 40 minutes. And it's really just going over the mark scheme, because once you see the mark scheme, or at least the example mark scheme, which is available on the website, it really helps you focus your exam when you're in the exam a bit more, and also your preparation. So we'll just go through the mark sheets for all 4 examinations: history taking, communication skills, and station 5. And I really hope from this talk you'll begin to see that actually you can already score points before you even enter the exam. Yeah, so a bit of prior, well, I'm sure you guys have prepared extensively, but there are some things that will come up, and there are some things you can already prepare for. And I hope this talk will highlight that. So the respiratory examination, when I did my PACES back in 2018-19, I felt fairly comfortable with this. I did a respiratory job, and also, on the acute take, you assess lots of patients with respiratory disease. But these, for the exam, for the 4 examinations, these are the 5 domains they will assess you on. Yeah, the examination, picking up signs, your differential diagnosis, clinical judgment, which is essentially your management plan, and then maintaining patient welfare. Specifically for the respiratory exam, on the sample mark sheet, the thing you need to be really, really slick at when it comes to just performing the exam is inspecting, palpation, percussion, and auscultation of the chest. And that's probably not a surprise to you. But if you do this well, you will score well on this examination. You need to show the examiner that you've done this 100 times before. Yeah. For me, the way I did my examination was I would always examine the posterior chest before the anterior chest, because I know that's where I'd find the most signs, for example. But whatever you do, have your approach, maintain it, and don't change it on the day. Yeah. But you need to be really, really slick at palpating, percussing, and auscultating. Yeah. And if you're good at that, you'll pick up physical signs. This section, really, the only way to really get good at picking up physical signs is to practice beforehand and seeing lots of patients with a variety of signs. Now, these 2 skills, differential diagnosis, clinical judgment, this is where you can really score your points before you go into the exam. I mean, you should already have an idea of the kind of, or the selection of cases that might come to PACES. Yeah. Before you go in, you have a blurb saying this patient has had chronic shortness of breath, please examine. You all know the differential diagnosis of a patient who's short of breath. Yeah. So you can begin to construct that even before you go in. When it comes to clinical judgment, your management plan, you have all managed somebody who is short of breath hundreds of times, I'm sure. You will do an ABG, some bloods, a chest x-ray, very basic things. For example, in my PACES case, I had somebody who was short of breath, they had interstitial lung disease, and then I proceeded to give them my basic management plan. Yeah. So, and for example, if you had a patient with a productive cough, they might have bronchiectasis. That's no surprise. And then you know how to investigate somebody for bronchiectasis. You could say I might do a high resolution CT thorax if you wanted to, but I would try and keep things very basic and very simple. Yeah. They just want to see that you can order very basic investigations. So then when it's time for the post-take ward round, those things are available, so the consultant can then make a final decision. Maintaining patient welfare, again, this should be banked. You should get these marks. Treating patients with respect and dignity. The one thing I will say for the respiratory and cardiovascular examinations when it comes to maintaining patient welfare is that I had a female patient. And when I went in, she had a sheet that was draped over her and she was wearing a bra. And when I went to examine the chest and the precordium separately, I said to the examiner, I would now like to ask the patient if she could remove her bra. The examiner said, ask her. So I asked the patient, she removed her bra and I examined her. And that was fine. I passed both stations. But just by asking and doing it in a nice, polite way, it showed you're thinking about the patient. Yeah. So you can already score these points just by being nice. And you should already score these marks because you have a fairly good idea of what might come to PACES. And even if you get a case and you have no idea what's going on, you can all have a differential diagnosis of somebody who's short of breath. And the investigations for a respiratory case are always going to be pretty similar. A combination, of bloods, ABG, X-ray, and a few bedside things, looking at the sputum, sending off the microscopy color sensitivity, those kinds of things. Yeah, nothing too extraordinary. For the abdominal examination, the key things that they will really be assessing you on is, of course, inspection, but also palpation, percussion. Can you pick up a mass? Can you pick up big organs? And the ones you're really going to be assessed on in this station, liver, spleen, kidneys. That's probably not a surprise. And ascites. So even if you're probably not so good at it, you need to show that you're good at doing it. And you need to show that you've assessed for all of those organs on examination, because they need to see that you are thorough in your examination. And the patient may not have any of those signs, but you need to get the message across that you've done this lots of times. So really, I'm sure you've all done this, and you'll have more opportunity during the course to feel for the liver, spleen, and kidneys in the right way and being able to pick them up and describe them. Again, to really get good at picking up physical signs, you just need to practice, guys. You need to have a partner. After work, you and your partner go around and you examine patients and you present to one another. And you need to see a variety of patients. And then again, differential diagnosis. This is where you can really begin to bank your marks. For example, you might get a patient with chronic liver disease. Yeah, very stable, very common. Or a patient with splenomegaly or a renal transplant case. All very stable patients. And you all know how to work these patients up. Yeah, you all know what kind of plan you would suggest for these patients. And you all know how to present a case for chronic liver disease. Yeah, it's just a script. So just get familiar with that. In my PACES, I had a patient who was, they were actually from the ward. I'm pretty sure they were from the ward actually, and they were jaundiced. And again, when I came to give my diagnosis and differentials, it was pretty straightforward. Yeah, you all know what the differential diagnosis of jaundice is. I don't think I got the right diagnosis, but the fact that I gave a variety was good. And the investigation for somebody who is jaundiced is basically very straightforward. Yeah, blood tests, ultrasound abdomen. You would maybe do an acidic tap if they have ascites. It's not complicated. So just go over that routine in your own time, yeah? And then maintaining patient welfare. In the abdo exam, again, the patient had their abdomen exposed and they had a sheet over their abdomen. And when I was examining their hands and I was examining their face, I kept the sheet over their abdomen and then I exposed it at the relevant time. That's just what I did. People may expose it before they examine the hands and face, but I did it that way to maintain patient welfare. History taking. So again, nothing is going to surprise you about this mark sheet. You get 14 minutes to take a history. That's a long time. And then a minute to reflect, and then 5 minutes basically for questions. And they'll always ask you the same questions. As for the examinations, present your findings. What's your diagnosis? How do you manage this patient? And again, you can see, if you look at this clinical communications skill section, you just need to do a history, guys, yeah? History of presenting complaint, past medical history, drug history, family history, social history. And it's really important that you do a systems review. You'll all have your own way of doing systems review, just do it. Yeah, don't deviate from it, just do it. So just get, before you go into the exam or as you prepare, have a form of systems review. The other really important thing, which can sometimes be forgotten is to ask the patient, how are your symptoms affecting your job, your lifestyle, your day-to-day living? Yeah, you'll get marks for that. And then when it comes to managing patient concerns, I mean, we've all done this, even from medical school. But in the exam, I would just ask in a very direct way. Yeah. Do you have any concerns? Is there anything that's particularly worrying you? Obviously within the context of the history, but just ask directly in a nice way. And then as soon as you say the word concerns, the examiner will see that and think, oh, he said managing patient concerns, tick. Make it easy for the examiner. And the other thing I will say is your body language is so important. And in your body language, you need to really demonstrate that you are actively listening. And you'll all have your own ways of doing that, either nodding your head or repeating words back that the patient is saying, which you think are very important. But just show that you're listening and that you care. And then again, the examiner will ask you, based on the history, and what is your most likely diagnosis and your differentials. The patient may also ask you this, yeah, and it's okay to say, I'm not sure, or to say, but you don't say maybe you're not sure, but maybe perhaps just say what you think might be going on, but explain it in layman's terms. So for example, in my case, I had a patient with recurrent falls, and they were on, I think, 2 or 3 antihypertensives. And I just said to the patient, I think your falls may be related to your medications, or another possibility could be an abnormal rhythm in your heart, which is making it go too slow. And then I said, well, the way we're going to investigate this is that we will just check your blood pressure with you sitting down and standing up. And then we'll do a tracing of your heart. And that was fine. And that's literally what I said. And that was my management plan. And that was fine. Yeah. And then I think that's what the examiner wanted. And they just prodded a bit more and they asked a few more advanced questions. But that is a very sensible management plan, given the presentation. And then, yes, so clinical judgment is, again, your management plan. You all know how to work with a patient with recurrent falls. Yeah, you do this all the time. And there'll be other cases that I'm sure you're familiar with. But there are example cases of history taking on the MRCP website. Have a look at those. And then maintaining patient welfare, again, asking about concerns, asking about how the symptoms are impacting their daily living. All of this will contribute towards this as well. Yeah. And you're just treating them with respect. The cardiovascular examination. You'll all have your own way of examining the cardiovascular system. I'm sure we will probably have a very similar way, but the key skills based on this mark sheet, which they'll be really looking at, is how you examine the pulses, radial, brachial, carotid, rate, rhythm, volume. They want to see that you're competent at that. And also the other big point from this examination is assessment of the JVP. You need to be professional in the way you do it, and you need to look like you've done it lots of times before. The next big skill for this station is really palpation of the precordium, and then obviously auscultation. And you're only really going to get good at these examination skills by doing it lots of times on real patients and picking up signs. And I would just say, try not to miss. It's very easy for me to say in the heat of the moment, you panic a bit, but just try not to miss obvious signs. But the more you do this examination, the better you become at keeping your nerve and, being able to think clearly. Differential diagnosis. I mean, for cardiology, there's lots of differential diagnoses for various murmurs, but it's very likely you might get a patient with a murmur or prosthetic heart valves or median stenotomy scar. And you'll know the differential diagnosis, for these things. In my PACES, I had a patient with Eisenmenger syndrome. Now, I'd never seen a patient with Eisenmenger syndrome before, and it took me back. For the first 30 seconds, I was like, what is going on? But then I just thought, I actually thought back to this mock sheet and I thought, right, just do your exam, just do the CVS exam. You'll get, you know, you'll, if you do it well, you'll get a tick for that. I could see the patient already had blue lips, for example, so I already picked up that sign. Yeah. And although I picked up a few signs, I probably missed a few as well, but I passed. And I had no idea how you work a patient with Eisenmenger syndrome. Yeah, but that's not the point. The point is that this is a patient with a cardiovascular disease. And I think, you know, for almost all patients, an ECG and an echo are going to be the right thing to do. So that's what I said I would do. And again, that was fine. And again, maintaining patient welfare. I had a female patient, she was wearing a bra with a sheet over the top. I only asked her to expose the sheet and her bra when it was time for me to examine the precordium. And then after I finished examining the precordium, help or say to the patient, do you want me to help you put your bra back on? Which obviously she said no, and put the sheet back on. Yeah, but just show like you actually, you know, that you care about the patient. Yeah, I think that's really important to do that. You know, if it is a female, even a man, just say, do you want help pulling the sheet back on? Yeah, because that will you'll score for that, I think. The neuro exam. I actually quite enjoyed doing this examination because there's so many different parts of the neuro exam. You know, upper limb, lower limb, cranial nerve, a Parkinson's specific exam, a cerebellar specific exam. But it doesn't matter what kind of exam you do, the thing they're going to really be assessing you on is how good is this doctor at assessing tone, power, sensation, reflexes, coordination, cranial nerves, depending on your case. And you know what I'm going to say, yeah, you're only going to get good at this by practicing lots. The more you do it, the more professional you look. But I think the neuro case is quite good because they're going to have signs and the signs will often be quite obvious, I think. For my PACES, I had a patient who essentially had lower motor neuron signs. And you all know how the differential diagnosis for that and how you would investigate a patient with lower motor neuron disease, for example. But when it comes to differential diagnosis, again, there are very common cases that will come to PACES: cerebellar disease, peripheral neuropathy, Parkinsonism. And then based on that, you then just give a management plan. And again, you can work on this before you even go to the exam. So if a patient has got Parkinsonism, for example, you know, you would say to the examiner, this is a clinical diagnosis, but I would review the drugs chart for drug-induced Parkinsonism, or I would do a mini mental state examination for Lewy body dementia, or I might do a CT head for normal pressure hydrocephalus. All of these, like, you know this, so just say it, yeah? I guess you could also say you might do a DAT scan, which is a scan to look at dopamine uptake and substantial nigra, but I wouldn't go there. You know, don't be too advanced in what you say, just keep it simple and say with confidence. Yeah, so I think, again, you can prepare your differential diagnosis, for example, of a patient with peripheral neuropathy and how you'd investigate that. And again, maintaining patient welfare. I actually had a patient who I think, well, I actually don't know, it was quite a tricky case. They had some form of lower motor neuron disease. I don't think I got the right diagnosis, but I gave a good differential. And I just gave my management plan. I didn't know if, and again, the way you work up somebody with a lower motor neuron condition is pretty standard, pretty straightforward. And I did it. Communication skills. Again, this is quite a long station, 14 minutes with the patient, a minute to reflect, and then 5 minutes for grilling. There are lots of examples actually of communication skills on the MRCP website, so definitely have a look, print them, go with your colleagues and just practice. And I guess when it comes to the actual clinical communication skills, from talking to other colleagues and doing the exam myself, I think the feeling I got was that the examiner really wants to see that you can guide and organize the consultation. Yeah, you're in charge, and it might not be a patient. It might be a relative or a healthcare worker, and they may or may not be an actor. Mine was an actor, for example, and it was a relative. And they really want to see, and you guys do this all the time, you speak to families, they want to see that you can explain things in layman's terms to the individual, yeah? And again, patient concerns, again, I would just ask directly, yeah, because saying, do you have any concerns, anything worrying you, immediately the examiner looks up things, right, they ask patient concerns, tick. And again, I cannot emphasize the importance of body language and showing that you're actively listening, yeah? And the other thing I will say in this station, which kind of touches on being empathetic, is that you might need to give emotional support, in the sense that if you discuss DNA CPR, that might be quite upsetting. Yeah, so you might want to say, would you like a tissue, or is there anybody else I can bring into the consultation to help you through this? Just to show that you're thinking about them. And something I always find that's quite helpful is put yourself in that position. How would you want to be treated? And then you can probably figure it out. Clinical judgment, again, I mean, this really depends on the case that you get. I think there are a few key themes that tend to crop up from my experience. They really want to see that you're going to act in the patient's best interest, and that really, and often that might be deciding treatment, for example, whether you do CPR or not, and balancing the benefits and risks of that treatment. Another thing which I think is important, and this kind of touches on a bit of basic ethics, is respecting the patient's autonomy, assuming they have capacity. Yeah, patients can make unwise decisions, and that's fine, so long as they understand the decision they're making. Duty of candor, I think, is another important aspect. And I think really you might get a case where a mistake has been made. And in that situation, you need to act with honesty and truthfulness and accept the mistake, apologize, give a plan of how you rectify it and how it won't happen again. That's quite a common scenario. And obviously not doing any harm. And I think a basic knowledge of a bit of medical law and ethics is needed, but not a comprehensive, in-depth knowledge. But again, I hope I've shown you that even on this station, you can already begin to get some marks before you even enter the station. Yeah, asking concerns directly, having good body language, and respecting the patient. Yeah. And again, you can practice some of the scenarios that may or may not come up. Station 5. I guess this was a station that I was most anxious about, and it's not as challenging as it seems. In some ways, as an examiner, you could argue it's a fairly straightforward station, in the sense that everything you do in this station has to be very focused. And personally, I quite like that. I like just getting to the point, examining what needs to be examined, and just doing the tests that need to be done. Yeah, rather than, in the cardiology exam, looking at the nails, looking at the hand. I just think, obviously in the exam you do that, definitely you must do that, but this station allows you the opportunity to just really be a bit more focused and think. So I'll just give some background to say, I'm sure you know this already, but before you go into the exam, you have 5 minutes. In that 5 minutes before you go into the station, you'll be given 2 cases, read both cases, okay? And begin to formulate what you think is going on, the questions you're going to ask, the examination you're going to perform, and if it's forthcoming from the information, maybe what the diagnosis is, the differential diagnosis, and the patient will ask you, yeah, that they will have some concerns, guaranteed. So ask them, do you have any concerns in this when you're in this station? Yeah. And you'll score marks for that. And then you can give them your plan, and then you'll have to present your case, obviously, to the examiner. But again, if we look at this in a bit more detail, you can see clinical communication skills. They really just want a focus history, really focusing on presenting complaints. And then your examination, it just needs to be focused. Yeah, it needs to look slick. Clinical, and then managing patient concerns, make sure you kind of incorporate that into the clinical communication skill. And then clinical judgment, you just make a plan. Picking up physical signs, again, you need to just examine lots of patients. For my state, maybe if I give my cases actually, and we can go through this, it might put this a bit more into context. Before I went in, I had a 50-year-old man who had progressive, well, actually very rapid onset weight gain, visual disturbance, headache, and skin changes. And I knew that endocrinology cases are quite common in station 5 or rheumatology cases, but I thought this could be Cushing's. You know, so after I went in, introduced myself, confirmed the patient's identity, washed my hands, I just asked him, what brings you here today? And then the actor, who's actually very slim, just gave me loads of information. And you might have to try and stop them talking, actually. And then the history, the diagnosis was clear from the history. Yeah. And then after that, I just did a very focused examination specifically for Cushing's. I looked at his abdomen for purple striae and skin. I assessed for proctomyopathy. I made him cross his hands and stand up. He couldn't do it. And then I just did a very brief cranial examination to look for any hemianopia, which he had. And then that was my brief history, my focused examination. And then I said to the patient, I didn't say you have Cushing's disease. I just said, I think there may be a problem with your hormones. I need to do more tests to investigate. His concern was, what's wrong with me? I'm really worried. I'm putting on all this weight. And I said, at this moment in time, we're not sure, but it could be your hormones. We'll do some more tests. And he was happy with that. And I said to him, we'll do some blood tests. We may also do a scan of your brain. And that was it. So hopefully although it may seem daunting, this station is not as bad as you think. The information will be there. Yeah, there will be clues in the blurb beforehand and also in the patient. Pick up on those clues. So you really need to actively listen. And you must ask about the patient concerns in this station. The other case I got was a pregnant lady with a headache. And I mean, it was intracranial, idiopathic intracranial hypertension, basically. That's essentially what it was. And again, you've all seen a patient, it doesn't matter, well, it doesn't matter if she's pregnant, but you've all seen a patient with a headache. And the investigations and differential diagnosis are fairly straightforward. So just don't forget that. And even if you have no idea what's going on, but you can think, right, this could be the neurological system, or this could be the cardiovascular system, you know the investigations you will do. So you can get marks for that. But I just want to, this station 5 is not, I promise you, it's not as challenging as you think. And when you come to the course, we'll go through cases and we'll really get your confidence up in doing this station. Yeah? So yeah, the more you practice, the more you will score marks in those first 2 domains. Just doing the examination, because you will look slick and thorough and you just look fluent. And the more you practice, you'll pick up signs. And the more patients you see, you'll begin to pick up a variety of signs. And then the next 2 skills, for example, differential diagnosis and clinical judgment or management plan, you've all done the reading, you've all passed part 1, you've all passed part 2, yeah? You know how to work up patients for compresenting complaints. You'll probably get a compresenting complaint in your PACES. Although the disease might be rare, the presentation will be quite common. And you all know how to work up these cases. And then, yeah, just be nice to the patient, basically. And you can do it. Yeah, and guys, honestly, I promise you, it's not as daunting as you think. If you prepare well, you will do well. Just hold your nerve. Yeah, and I'm sure you'll all be fine. And when we meet in a few weeks' time for the course, we can talk about whatever you want to talk about, go over where we need to go through, because we all want you to pass. Everybody wants you to pass. Yeah, and they will try their best to help you pass. But if you miss obvious signs, if you don't treat the patient with respect, then it's very difficult to pass you. That is me done. Please feel free to post any questions in the chat. Maybe I can also just give you my email address. And you can, if you don't have any questions right now, you can always ask me afterwards. But I hope you enjoyed that, guys. Maybe I'll just give a few minutes for questions in the chat if you have any. Yeah. So there's one question here. If a patient has 10 societies, do we still need to do shifting dullness? Really fantastic question. Yeah. Say to the examiner when you do, well, what I would do in that case is I would say during the examination, don't hold your nerve and just say to the examiner, this patient has 10 societies. I feel there's no need for me to do shifting dullness. And they'll say to you, that's fine. Or they'll say, please show me how you would do it. But by asking that question, it shows two things. Number one, that you clearly know the societies and that you're a competent doctor, but also you're thinking about patient welfare. Why am I doing something when it's already clear? Yeah, so that's really, really good. A brief overview of your course, please. I will just give you the website for that, and you can have a look. The dates for the course, that we don't know just yet, but we'll give more information in due course. It'll all be available on our website in time. On a case you don't know the answer for, especially cardiology, what to say? Really good question. Number one, you can be honest and say, I'm not entirely sure what the diagnosis is here, but you need to at least have a differential. Yeah. And when it comes to cardiology, I mean, there aren't really just you can have a problem with the heart rhythm, the valves, or the heart muscle, or the vessels. Yeah. So you could just say this may be some form of cardiomyopathy or something. Just have an idea of what may be going on. And if you don't know, say you don't know, but that's fine, because that often happens in medicine. But just say, I'm not sure what's going on, but this is how I would investigate the patient, by doing an ECG, by doing an echo, by speaking to my senior. I think that's reasonable, but you should at least have a rough idea of what the differential diagnosis could be. Yeah. I mean, it's highly unlikely that you'll see a case where you have no idea what's going on. And the examiner wants you to pass. Yeah, they're on your side. So they will encourage you. Okay. In the abdo station for shifting dullness, should you say you will wait for 30 seconds, ideally? I would just say, yeah, well, good question. I mean, if you think they have got ascites, it depends really how slick you are on your examination. If you're quite quick at doing it and you have the time, you can wait. But if you're a bit short for time, just say to the examiner, normally I would wait for 30 seconds. Yeah. But if you think they have got ascites, then I would wait. Maybe not 30 seconds, maybe, I don't know. Well, yeah, I guess that is the textbook answer, is at 30 seconds. But I think if you think they have ascites, wait 30 seconds, and the examiner will say, and if the time is being prolonged, he'll say, you don't have to wait for 30 seconds, please continue. Or you could just ask the examiner. So that's a lot of answers. So what I would say actually is, should you wait for 30 seconds? Say to the examiner, ideally I would normally wait for 30 seconds, but in the interest of time, I will continue. Okay. In the case of the pregnant lady, do you have to check BMI as well as the ophthalmic? Really good question. So my patient, who was a pregnant lady, was actually an actor. So I went in, and it was just a lady who was not pregnant. So I was a bit confused. I wouldn't say that to try and put me off. Anyway, so I just proceeded, and then the BMI was actually on the sheet beforehand. But yeah, that's a really good question. I would, at the end of your examination, say, I would like to know the BMI. And then I went to look at the ophthalmoscope, and the examiner said, don't bother. So I didn't. But I think the fact that I went to grab it showed intent. Diastolic murmurs are hard to hear, but the way you're going to get good at that is by practicing and by seeing patients who have those murmurs. Basically, that's all I can say. I was quite lucky because I've always been at a teaching hospital, actually. So I've always been lucky that I've had a variety of patients available to me. But you know, picking up physical signs is only one section of the mark sheet. If it's a hard murmur and you don't pick it up, they're not going to really, you're not going to fail for that. But there should already be other clues on the examination. And the way to pick up those other clues that can point you towards your diagnosis by practicing. And even if you don't get the right diagnosis, just give a differential. Okay, and you'll score for that. Even though you don't get the right diagnosis, that's fine. Often we get things wrong. We're all not so good that we can examine a patient, know exactly what's going on with them. We don't. But the thing is, you have an idea, and you then just propose your investigations, ECG echo. Okay. Any advice for the ethics communication station? Yes, go on to the MRCP PACES website. There are lots of cases. Print them out, read them, practice them. That's what I would do. You only get good at that is by practicing. Will there be another one-day crash course? I think Azim has replied to that. Yeah, so the best person to email is, so in terms of any more dates, Mike, here's the person to email. And then you'll be me. Okay, if you pick up a finding but not sure about it, would you, I guess you can't. Exactly. Very good, Samaya. You definitely cannot make up findings. But if you pick up a finding you're not sure about, yeah, so really good question. This is where your ability as a doctor and your ability to hold your nerve comes in. If the finding is consistent with what you think is going on and other findings, say it. If it's not quite in keeping, then don't say it. But the examiner will ask you your findings, and if they think you've missed an important finding, they will say anything else, and then add it in. Because maybe you have picked that finding up, and maybe you're not feeling confident, but maybe you have picked it up. If you don't say it, the examiner will prod you for it because they want you to pass, yeah? But definitely do not make up signs. Yeah, nobody wants to, yeah, just don't do it. Okay, guys, I think that's all the questions for now. But Yeah, feel free to ask. You can email me. Let me also give you my university email address. Okay. So yeah, email me and whatever you want, because I know how difficult it is to go through practicing for this exam after you've been working all day. So any help I can give you, I will, to make it easier for you. And just spend time practicing and spend time having an idea of what your differential diagnosis is and your investigations are, because the examiner is going to ask you that. And on the MRCP website, PACES website, there are really good example history taking communication skills. Print them, read them. But otherwise, guys, thank you very much. Nazeem, thank you very much for organizing this. And we will see you soon. All the best.